Nice to meet you. It's an honor to be here with you, and thank you very much for the invitation. So I will present my tips and tricks for the Basilica procedure. I just want to say first that it's not a step-by-step presentation. It's just to show with you the issues that you can have during these kind of procedures and how can you solve them. So this is going to be the talk. It's just what can you do when you have these procedures. So first of all, when to do it. So I was here in the last presentation, and you already saw the risk factors. So we use mostly the same risk factors that you have been hearing, but it's very important to have in mind that this 10 millimeter coronary ostium cutoff is not enough, because what we need to see is the relationship, as you saw in the prior presentation, between the leaflet and the valve that we are implanting. So it's not just about the coronary ostium height, it's also the relationship between the leaflet, the STG, and the valve that we are implanting. So how can we select these kind of patients or identify these patients? Well, first, it is true that if the coronary height is low, it's a red flag. But after you identify these kind of patients, you will need to measure the distance between the coronary ostium and the leaflet height. You will see an example after this. So if the ostium of the coronary is higher, then you have a risk. If not, the risk is low. So if the coronary is below the coronary ostium is below the coronary leaflet, then you have to measure the distance between the valve and the ostium of the coronary, what is called VTC. And if the VTC is lower than 4 millimeters, then you have a high risk of coronary obstruction. On the contrary, if this distance is wide and you don't have a short distance between the valve and the ostium, then you need to measure the volume of calcium, because sometimes you have distance, but you have a very thick calcified leaflet. So in these cases, you have a high risk of coronary obstruction. So this is an example of how do we measure this. So this is a standard trimension, and what we are doing here, as you will see, is we are scrolling up, and you can see that the ostium of the coronary height is just in front of the leaflet. So in this case, the leaflet is above the coronary ostium. So we have a high risk of coronary obstruction for this patient, and we go to the second step. And in the second step, we measure the annulus, so we know what kind of valve we are going to implant, and we do a virtual implantation of the valve. In this case, it's Sapien 26. We implant the valve, and then we measure the distance between the valve and the coronary ostium. And in this case, we have a space, so we have a VTC that is larger than 4. So we will have to go to the next step and measure the volume of calcium. So we are measuring individually the volume of calcium, and in this case, the purple one is the left one, and you can see that the volume is higher than 600. So even with a patient that has a VTC less than 4, in this case, the patient will have a high risk of coronary obstruction. So it's important to have in mind that it's not just the coronary height, but the relationship.
소리 안 들려요?
Can you see the example 1 and example 2? No. Yeah, no. You have it. So in this case, this is the example 1. The coronary height was quite low, but we have a space because the sinus it's large, so we don't have risk. On the contrary, the second patient had the same coronary height, but the sinuses are quite small, so we have a risk of coronary obstruction. So this is how we do it, and then it's also important to know when not to do this kind of procedure. So it's in patients with eccentric coronary ostium. Here you're looking at the CT of a patient with a very low right coronary ostium, but the ostium is very eccentric in relation to the leaflet. So even if you do basilica, this won't protect the coronary. Also, it's important to know that there are some bioprostheses that cannot be treated with this kind of procedure. For example, the freedom. The left prosthesis that you're looking at has like a skirt, so even if you destroy the leaflet or modify the leaflet, you will still have risk of coronary obstruction. So the next thing that we have to do is to plan the procedure. So there are some steps, and only a few steps. The first one is to have a specific projection to work. So we mark, as you see on the left, a point on the ostium of the leaflet that we are going to modify. And then we have two specific projections, the side view in which we isolate the left ostium and the end face view in which we see the ostium of the coronary in the middle of the sinuses. Sometimes this projection, as you can see, the end face view, it's very, very stepped, so we cannot reach that. This example is 60 RAO, so it's very difficult to do that. So that's why we see if the catheter is in the middle of the coronary with TE. That's a very important thing, because sometimes with angio is not enough. The other thing that we have to look on CT is the distribution of the calcium. As you can see here, there is a small spot without calcification, and we should aim to that spot because transversing the leaflet in this huge amount of calcium will be impossible. Now, for the equipment, it's very important to have the equipment before the procedure, because it will the specific equipment before the procedure, because it will simplify a lot of the procedure. And this is the equipment that we use in our hospital. It's very, very important for us. Our recommendation is to try to get these AL catheters with 3 or 4 curves, because as you will see in the next slides, it can really simplify and increase your support when you are doing the leaflet penetration. And another important recommendation is to be sure that we have our secure vascular access, because once you modify the leaflet, it will be mandatory to implant the valve. So this is an example of a case in which you can see there is a huge calcification and tortuosity in the iliac artery. So if you don't have a long sheet, you cannot do the procedure, because you will probably modify the leaflet and then you will struggle to do the implantation. So you're looking at the right. Once you already have the access, then you can go ahead with the procedure. But if you don't secure the access, it's very dangerous to do this kind of procedures. So we'll go to the leaflet puncture. This is usually the most difficult part of the basilica procedure, so you have to be very patient. Usually it takes a little bit of time, so just be patient. And if you're having issues, then you need to identify what kind of issues and try to solve them. What kind of issues you can have when you're puncturing the leaflet? Well, first, you can have issues with the direction of the puncture, you can have issues with the support, and you can have issues with the localization of the catheter. So first, the correct angle of direction. This is very important for native basilicas, because you don't have the stent of the valve, so you are not looking really at where do you need to puncture. So as you can see on the left part of the screen, the catheter here, it's aiming at the right part of the screen, so you're pointing into the left atrium. It's important that the direction in this projection, which is the side view, it's pointing downwards. And as you can see on the right part of the screen, we have a mother and child catheter, so it's an AL catheter, and inside a JR diagnostic catheter. So you can go into the base of the leaflet, so very distal into the base of the leaflet, and then point downwards, so you don't go into the atrium. And so when you change into the end space view, you need to have the catheter just above the coronary ostium, not pointing anterior or posterior. So you're looking on the left side that the catheter is pointing anterior, and on the right part that it's pointing really downwards. What can happen if you don't have a good direction? Well, this is an example of a perforation of the anterior leaflet of the mitral. It's not dangerous if you look at this and you identify that this is happening, then you just direct the catheter. But if you are not aware of this kind of issue, you can snare also some chordae or the leaflet and ending up lacerating the mitral and the aortic valve, which obviously can be very, very, very dangerous. This is for the side view. And for the end face, you can see here that the catheter was pointing anterior, and then the perforation will go into the septum, and obviously the wire won't go into the LV. So it's very important.
또 안 들립니다, 기술팀.
It goes very smoothly, but if you see it on the angio, you will need to see the point of the catheter going into the apex of the left ventricle. So if you go to right, you will see that actually the wire is going posterior. So it's going into the left atrium. So that's why it's important just to be sure on TE and also on floor that you're going. If you use a 7 French, then use a diagnostic 5, because if not, you will have a lot of issues manipulating the catheter. And if you don't have long JR catheters, then you can just cut the guiding catheter as we do with the CTO's procedure. This is a very strong recommendation. Please, if you're doing this procedure, try to get an AL3 or LA4, because it will really simplify your life. And if you're going for the right, usually with a multipurpose or JR catheter will be enough. So this is an example in which we don't have a good support and we cannot penetrate the valve. So this is an AL2 catheter, 6 French. We didn't have the other catheter. So the position looks quite good, but actually when you start to penetrate, you can see there that we don't have support. So you start to bend the wire and it will be kind of a nightmare. And this can be simplified using the right guiding catheters. As you can see here, on the right side, we have an AL2 6 French. On the left side, we have an AL4 8 French, and it just goes like butter. So with a very good support, you can simplify the procedure. Another recommendation is just to be patient, because you're perforating a calcified leaflet. So as you can see here, we're trying to perforate, but we are in the middle of the leaflet. We cannot go there. So just remove a little bit the wire, move a little bit the catheter, and find the spot without calcification, like here. So this is the same patient, just moving a little bit the catheter, you can find the good spot. After you transverse the leaflet, you need to snare the wire. And the recommendation are use a gooseneck snare, size the snare according to the LVOT, usually at 20 or 30 millimeters, it's what we use, and put the snare really close into the aortic valve. You can see here that we are transversing and going really inside into the snare and getting the wire, but sometimes it's not that easy. And you think that you go very easily, you transverse like that, and you cannot get the wire, so you need to start to manipulate the snare. and get the snare, as you can see here, very away from the aortic valve. And the issue is that you can have some chordae, mitral chordae, and this can be very dangerous. So just before doing the laceration of the leaflet, you can see the differences here on the left. The snare is very close into the aortic valve, and on the right, even if we are pulling the catheters, we have a very large space between the aortic valve, and so there's a large curve. So we have the mitral chordae here, and this is something that you can see on TE also. So it's very important to try to snare the wire in the very close into the aortic valve. And if you cannot do that, then be sure that you don't have the mitral chordae. Okay, you can see there that it's very close into the aortic valve, and on the other side, even if we pull, we have this long distance because we have the mitral chordae. So once we have the snare, we will do the laceration of the leaflet. And to do that, we need a flying B. I will show you what is that. We need to move the catheters as a single unit, and sometimes we need to do a balloon-assisted basilica. So this is the flying B. This is something that we do to lacerate the leaflet. So very, very sharp angle curve on the wire, because what we are doing is we are cutting the wire with electrosurgery. We are not like destroying the valve, but we are doing a smooth cut with electrosurgery. And also it's important to move the catheters as a single unit. Here we have two examples in which, because if you pull the wires, then the catheters will dive in and they will cover the wire, and the wire won't be exposed, so you cannot lacerate the wire. You can see in both examples that we are pulling the wires and the catheter are going inside. So to do that, you have two maneuvers. The first one is you can have a lot of people, like one holding the catheter, the other holding the wire, and the other pushing the button. Or the most simple one is, as you can see here, you just put a clamp on both catheters, as you can see on the red arrow, that if you put a wire there, a clamp, then you just pull the wires and everything will move together like this. So here we are pulling and the catheters are not touching each other, so you can do the laceration. Sometimes we have a very, very calcified valve and it will be very difficult to just lacerate. So what we do is something that is called balloon-assisted basilica. This is an example of a very calcified valve. So the penetration of the leaflet was quite easy because we were able to find the spot without calcification. We do the snaring, as you can see here. And before doing the laceration, you just advance a standard coronary balloon, 3 millimeters balloon, to facilitate the laceration of the leaflet. There are some people who are doing this also with shockwave. We cannot do that because of reimbursement, but it's probably something that you can do if you want to facilitate the basilica procedure. So this is the same case. Even if you have a very, very thick calcification, you can do the leaflet laceration. You can see on the right that the leaflet is completely lacerated. You can see the calcification moving just at the right side of the safari wire. And the last recommendation is that always, always, always perform a selective coronary angiography after doing this kind of procedures, because what you can do is, this is an example in which native basilica, you do the laceration very smoothly without any complication. Then you implant the valve. And if you don't do a selective coronary angiography, you won't be able to see this kind of thing that can happen after basilica. So here, you're looking at the coronary leaflet that was lacerated and it's prolapsing inside and outside the coronary ostium. So in this case, the basilica was successful, because if we haven't done basilica, then the coronary will be completely occluded. So in this case, we lacerated the leaflet, and the leaflet that we lacerated is going inside and out of the coronary ostium. And if you don't do a selective coronary angiography, sometimes you will miss that. And this is something that is not that rare, especially on native anatomies. So what happened with this patient? Well, the thing is that we obviously need to put a stent here because if not, the coronary can be occluded. But we were a little bit afraid that after putting the stent, the leaflet was outside the ostium, so we'll have the same issue of the leaflet going in and out. So what we did is we put a wire, obviously, and then start pacing the patient and inject contrast. And by doing that, we were able to move the leaflet inside the coronary ostium and to keep the leaflet inside the coronary ostium like this. So we're doing pacing, injecting with the contrast. And so we put the leaflet there, immobilize the leaflet, and then put a stent to hold the leaflet inside the ostium, so we don't have this movement of the leaflet anymore. As you can see here, this is the angio and the result of that. So as a take-home message, sometimes these techniques are required. It's important to know them. They are reproducible and effective techniques. There are some pitfalls that you need to be aware, and that it actually has a short learning curve, but it's very recommended that you have the first cases with a proctor, because if you have these pitfalls, probably it will be much easier. Thank you very much.
Thank you, Dr. Cueva. 이 마지막 강의가 우리가 바실리카에 대해서 배울 수 있는 아주 좋은 기회인 것 같아서 먼저 마지막 강의에 대해서 이런 토론하고 질문하는 시간을 가지도록 하겠습니다. 패널하고 혹시 플로어에서 질문이나 코멘트 있으면 먼저 해주시기 바랍니다.
Thank you for a nice lecture. I have a question about how can evaluate the effectiveness of Basilica. In other words, do you perform twice time if the Basilica was not effective, only one time?
Yes, to evaluate if the Basilica is effective, you need to do selective coronary angiography. And there are some publications of the Redichini group in Italy that they are also, because you have sometimes these borderline patients in which you do the procedure, but you have a little bit of material on the ostium of the leaflet, then you can do IBUS or you can do FFR. What we do is we just do a selective angiography, and if we have doubts, we do IBUS. And in patients with an extreme risk of coronary obstruction, we are still keeping one wire in the ostium of the coronary. And in patients in which they don't have like a very extreme risk of coronary obstruction, we are not protecting anymore. We are just doing the procedure without wire.
Thank you for giving your tips for Basilica. In your slide, you only showed the left side Basilica. So, in doing Basilica of right coronary leaflet, what kind of precaution or any special tips can you give us?
Yes, it's the right Basilica is much is less common. And that is good because the right Basilica is usually a little bit more difficult. And it's a little bit more difficult because the projections that you need to isolate the right coronary ostium are usually very difficult to obtain on angio. So that's one. And the second reason why it's a little bit more difficult is because of on the left, usually you, with an AL catheter and JR inside, you will have the position like 99% of the time. And on the right side, you usually start with a JR catheter, but depending on the angulation of the aortic annulus, sometimes it's the JR catheter is not that good enough. So in summary, right basilica, it's harder, it's less common, and it's harder because you cannot isolate the right coronary osteum usually on X-ray, and the catheter is more difficult to engage the exact spot.
Yes, I have one question. Thank you for nice lectures. So I was very impressive on your basilica procedure, especially in the native valve disease. So you classify the high-risk patient based on the cusp height and coronary height, and calcification and coronary height less than 12 millimeters. So I wondered that how many % of the patient classified into the high-risk patient, all of your TAVI patient, and among the high-risk patient, how many patients you have you done the basilica in your lab?
Okay, so it's around 3% of the cases. So we do 300 TAVIs per year, and we are doing around 7 to 10 basilicas per year. We have done more than 40 basilicas now, and we are not doing chimney stenting anymore, only for patients in which they have like a very eccentric anatomy. We cannot do basilica in those cases. And it is true, this is about basilica, but for valve-in-valve, we have changed and we are doing more unicorn procedures than basilica. But for native valves, we have done also unicorn in native, but I'm not sure it's the right way to go, because in unicorn, you destroy the valve with a balloon. And if you don't have the stent frame, probably you can damage the aortic root. So we are doing native basilicas basilica in native cases. So yeah, it's around 2 to 3% of the cases. And yes, we're doing more or less that volume.
Dr. Cueva, your lecture is very impressive for me, but the basilica procedure seemed a very complex procedure for me to perform freely in my clinical practice, and you showed several decision criteria for performing basilica procedure, cusp height relative to the coronary height, and the absolute coronary height, VTC, and calcification burden. So, do you also consider VT-STJ or the
Yes.
ST junction height or diameter, etc.?
Yes. We, especially for valve-in-valve, so we measure the virtual to STG, and usually it's 2 millimeters what we measure there. The leaflet usually don't reach the STG, but if you don't have a space, then you have to be aware when you have this combination of things. So sinuses of less than 30 millimeters and an STG, virtual to STG of less than 2 millimeters should be a red flag. And about the difficulty of this procedure, I think, I also perform CTOs, and I think that, and I truly believe this, that complex coronary procedures can be much difficult than this. So what I'm trying to say is that this is something that can be done and it's reproducible. Sometimes you need a little bit of help just in the first cases, just to be sure that you know the step-by-step. But it's not really a technical procedure. So I encourage you to go ahead and to try to start these kind of procedures, because I think, especially for young people and patients also in the future for TAVI will be a technique that needs to be done. There are some devices that are under development, the shortcut, for example, but for some people, it will be very difficult to get that device because I believe it's going to be quite expensive. So this technique can be reproducible, and if you don't have access to that technology, it can be very helpful.
Dr. Cueva, have you ever done Basilica in patient with bicuspid aortic valve? It may be a
No. This is a very, very good question. I haven't done that. I've seen cases in which it has been done, and now there are some people, including me, that think probably because the leaflet modification probably can help also not only for coronary obstruction, but also to modify the leaflet to help a better expansion of a valve, especially in patients with bicuspid anatomy. So that's probably something that we will hear in the future. So leaflet modification, not for coronary obstruction, but for valve modification to improve valve expansion.
Dr. Cueva, thank you for giving us the very excellent lecture and very informative tips and tricks regarding the Basilica procedure. Thanks again.
Thank you very much.